Good evening, all. Welcome from GICS team from Bengaluru. We're just here today to have a journal club on behalf of GICS program, and as a part of it, we are thrilled to welcome the Kerala team today from Pushpagiri Medical College, where Dr. Matthew Pulikan, Dr. Manju Matthew, both consultants from critical care team in Pushpagiri Medical College, have logged in, and we have presenter for the evening, Dr. Kirti, who is doing the DRNB training in the same institution, who will run through the said program, which is the journal review, including a restricted trial. And so I request Dr. Manju Matthew to moderate this session and give an opening comment before the talk starts. Thank you.
Hello, can you hear me?
Yeah.
Yes.
Good evening, everyone. I would like to first thank the GICS team, Dr. Pradeep, Dr. Anirban Chaudhary, Dr. Justin, and Dr. Ajit Kumar for giving us this opportunity. Dr. Kirti, our DRNB trainee, second year trainee, she has an MD General Medicine, and then now she's doing her training. She will be presenting the case. We have chosen the RESTRIC trial, and this trial was published just last month, and it's on restrictive blood transfusion in patients who are critically injured. As we know, massive transfusion protocol has become kind of a standard treatment these days for actively bleeding trauma patients. We also know that there have been quite a lot of studies on restricting RBC transfusion in critical care patients. Now, this particular trial is going to look into restricting RBC transfusion in bleeding patients. So I will just, I'll now hand over to Kirti to start the presentation, and I hope it will be a very interesting session and discussion. Kirti?
Thank you, ma'am. Thank you for the introduction. Good evening, everyone. Ma'am, is my slide visible?
Yes.
Okay. Good evening, everyone. Today's discussion will be on the RESTRIC trial. So as ma'am told, it is a very recent trial, which is published in the Journal of Intensive Care on July 24th of this year. It is a multi-center trial, which is conducted in 22 tertiary emergency centers in Japan. And it is about the restrictive RBC transfusion strategy in trauma patients. So coming to the background of the study, so the efficacies of FFP transfusion and factor transfusion have been widely evaluated in many studies, but the efficacy of RBC transfusion and the optimal hemoglobin target level in trauma patients have not been adequately investigated. So what is the clinical question of the study? So their objective was, in patients with severe trauma at risk of active bleeding during the acute post-injury phase, whether a restrictive RBC transfusion strategy was clinically non-inferior to a liberal RBC transfusion strategy. So moving on to the study methodology, this is the trial design. So it is a cluster randomized crossover non-inferiority trial done in multiple centers with 1:1 allocation. So the participants included in the trial are all the trauma patients who are aged more than 20 years with one of the following complications, that is either with severe bleeding that can result in circulatory shock, or with a suspicion of severe bleeding after arrival at ED, or even there is a potential, if there is a potential for severe bleeding postoperatively during the acute phase of trauma. So if any one of the following is there in trauma patients who are aged more than 20 years, they are included in the study. Either severe bleeding or suspicion of severe bleeding even, and even the potential for severe bleeding. But they excluded the following patients: those who were in cardiac arrest before or upon arrival at the ED, were transferred from another hospital, and in whom the physician's decision to withdraw the active treatment was done, and in whom there was complications of severe burns, more than 50% body surface area. Pregnant patients were excluded, and the patients with chronic anemia with a hemoglobin of less than 7 from the medical history, they were also excluded. And those who object the blood transfusion, they were also excluded. So the patients, trauma patients aged more than 20 years, as we discussed, if they have having active bleeding or having any one of the following to result in active bleeding, they are included after excluding the above mentioned cases. So what is the intervention done? So they are actually.
Can we just break here and take a look at the relevance of the research question and whether the objectives were clearly defined, and what about the inclusion and exclusion criteria? Have they actually included all the patients which they really wanted to in the study as per the objective, and have they excluded the relevant patients? What do you think?
Ma'am, regarding the clinical question or the objective of the study, it is actually very relevant. And as I already mentioned, there were many studies to find the tell the efficacy of the FFP transfusion and factor transfusion, but the optimal hemoglobin target level is still questionable, and it remains unclear in. And in the previous trials were not done in the trauma patients. They were done in a different subset of patients. Like they were done in critically ill patients and not who were actively bleeding, and septic shock patients, etc. So RBC transfusion strategy in trauma patients, and in the acute phase itself, this is the first study. So this is a relevant thing, and the clinical question is also very specific. To find the whether the restrictive strategy or the liberal strategy is better. And regarding the inclusion criteria, we have included mainly the trauma patients alone, and who are actively bleeding, and the patients with the chronic anemia and all which I mentioned, all have been excluded, which is also properly done.
Okay, carry
Uh,
you carry on to Dr. Kirti.
Okay. So what is the intervention done? So the intervention done here, the people are included patients are randomized into two groups. To one group, the restrictive RBC transfusion strategy was given, and the target hemoglobin was kept at 7 to 9. And the another group, they were randomized to the liberal RBC transfusion strategy, and the target hemoglobin is kept at 10 to 12 grams per deciliter. And the initiation of transfusion, that is the timing of initiation of RBC transfusion, is mainly decided by the judgment of the attending physician, and it was usually based on hemoglobin levels or the presence of hemodynamic instability. So for how long the transfusion strategy was followed in those patients? So it was followed either 7 days after hospital admission, or up to discharge from ICU, or up to the decision to withdraw the active treatment, or till death. And these patients were followed up for up to 28 days to know the outcome. So the outcome measured here is the primary outcome. As I told, they were followed up for 28 days. So the primary outcome was kept as 28-day survival rate after arrival at ED. And they compared the survival rate among the liberal and restrictive strategy groups. And the secondary outcome they have kept it as number 1, time to death during the first 28 days after arrival at TB. And number 2, in hospital survival rate. And number 3 is cumulative transfusion amounts. That is the transfusion amounts received by both groups, RBC, FFP, and platelet concentrate or measured. And even free days, they have measured the ICU free days, ventilator free days, and catecholamine free days during the first 28 days in both the groups. And they have also measured the organ failures developed in both the groups, and also the complications during in-hospital stay for the 28-day study period. And they have mainly targeted the complications like transfusion-associated lung injury or the TRALI, which is more common with liberal and even with restrictive, it can be possible. And infections more common with liberal. And they have also looked at the ischemic complications like bowel ischemia, acute MI, cerebral infarction, etc., which are more common with the restrictive strategy. And also the DVT, pulmonary embolism, or looked into in the complications. And the Glasgow outcome scale score at discharge from the hospital is also kept as a secondary outcome. Moving on to the sample size. So they calculated the sample size and
Can I stop you?
Yes, ma'am.
Can you you didn't explain about the randomization. Do you know what is cluster randomization?
The cluster randomization is different from the individual randomization. So this is a picture which explains the cluster randomization. So the first picture, it is the usual individual randomization, where all the individuals in the included in the study are divided into either of the groups. But whereas in cluster randomization, the clusters are divided into randomized into two groups. For example, each cluster can be a center, a village, etc. So, for example, here each center is considered as a cluster. We have 22 centers here. 11 centers are randomized to restrictive group, and all the other 11 centers are randomized to the liberal group. So this is known as cluster randomization.
And is it a good one? Is it a good type of randomization? It is a variant of RCT.
Compared to individual randomization, it has its own limitations because it is useful. It is useful only for population-based studies like mass vaccination, where schools or colleges or villages can be randomized into clusters and study. But otherwise, it has a risk of selection bias. And hence it is inferior to the individual randomization, which is commonly used.
Standard randomization.
Yeah.
Okay. You can continue with the sample size determination.
So moving on to the sample size calculation. So to reach a power of 80%, they calculated a sample size of 170 patients for each group, and hence a target sample size was set at 400. But actual sample size required was around 6,214, which was much larger than the target sample size, which is just 400, because there was an error in the sample size. And since it was not discovered until the end of the study, they couldn't terminate. So we have discussed about the randomization already. And this is a picture which explains the crossover done during the study. And as I told already, included example, 11 centers are randomized into restricted. Is 1 year of the study period, and after which there is a washout period for 1 month, and the next year those centers which were following the restrictive strategy, they followed the liberal strategy, and those which followed the liberal strategy followed the restrictive strategy for the next full year till the end of the study. So this is the crossover which they have done in the study. And as I mentioned, it is a non-blinded study since it was not possible. They have not blinded the groups. So moving on to the statistical methods. All the continuous variables were expressed as medians and were compared using the Wilcoxon-Rankin method. And the categorical variables were expressed as numbers and percentages and were compared using the chi-square and the Fisher's exact test. And the non-inferiority margin was set at 3%. And the null hypothesis was P1 minus P0 less than or equal to minus 0.03. So P0 is a 28-day survival rate of the liberal strategy, and P1 is a 28-day survival rate of the restrictive strategy. And intention to treat analysis and the protocol analysis principles were used for the primary and sensitive. Yes, ma'am.
Can you explain that non-inferiority margin? Do you know what is that? Can you just explain that?
Yes, ma'am. So as I mentioned already, it is a non-inferiority study. Basically, non-inferiority study, we compare two groups. That is, we compare actually new treatment regimen with the already established standard treatment regimen, and we try to prove that it is non-inferior to the standard one or the old one. So in other words, we are just trying to prove that it is not much worse than the standard one, rather than to prove it as a superior to the standard one. So this is the non-inferiority study, and in the non-inferiority study, we have a non-inferiority margin of 3%, which is used in the forest plot to determine the statistical significance. Ma'am, I think I'll be explaining it in the forest plot when I'm discussing the results.
Carry on.
Okay. So intention to treat and per protocol analysis principles were used for the primary and sensitivity analysis respectively. And secondary outcomes measured were evaluated using the Kaplan-Meier method and the log rank test. Hazard ratios were calculated using the Cox regression model, and the p-value of less than 0.05 is considered statistically significant. So the results obtained are, so as I mentioned already, the eligible patients after excluding the exclusion criteria were 1,045, and they were randomized into 543 in restrictive group and 502 in liberal group. And after excluding those who did not give the consent to participate, restrictive strategy had 222 and liberal had 200. And after excluding those who had transferred from other hospital, applied another strategy, lost to follow-up, etc. A restrictive strategy group had 216 patients in the intention to treat analysis, and liberal had 195. And among the 216, deviation from transfusion strategy was seen in 6 people, and in per protocol analysis, the restrictive group had 210 and liberal strategy group had 194. So this is a table which is showing the baseline characters of the population in two groups, and they were actually almost similar in both the groups. And here they have shown the sex, age group, comorbidities which were present in both the groups. They were almost similar. And regarding the antithrombotic agents prior to injury, those who were consuming antiplatelet agents, anticoagulation, or both, they were also matching in both the groups. And the type of injury, blunt or penetrating or both, were also matching in both the groups. And time from injury to arrival at ED was also matching. And injury severity score, or abbreviated injury scale score, which is used to assess the severity of trauma in ED, it is also matching among both the groups. And the physiological status, GCS, respiratory rate, heart rate, systolic blood pressure, etc., are also matching among the groups. And the laboratory tests like hemoglobin, platelet count, prothrombin, INR, fibrinogen, lactate, etc., were also matching among the groups. And the hemostatic intervention or non-hemostatic intervention done among the groups were also almost matching. This is a picture which is showing the hemoglobin level of the two groups during the first 7 days. So as you can see, during the start, the hemoglobin, since we have excluded all the anemia patients, both the groups had a hemoglobin of around 12. And as the days passed by, liberal group had a higher hemoglobin targets, and hence it was more than 10. And restrictive group had a lower target, and as planned, it is also in the planned range of 7 to 9. So this is a picture which is showing the cumulative volume of RBC transfusion in both the groups during the 28-day study period. So RBC transfusion cumulative volume is more among the liberal group and less among the restrictive group, whereas there is no difference among the cumulative volume of FFP transfusion among the groups. That is, they have restricted the RBC transfusion to the group, but otherwise other treatment is being given similar to both the groups. And this is a picture which is showing rate of patients without RBC transfusion during the 28-day study period. So as you can see, the restrictive strategy group has more number of patients without RBC transfusion. So this is the outcome table, and the primary outcome, 28-day survival, is around 92% in the restrictive group, whereas the 28-day survival is lower, 91% with the liberal group. So we'll be discussing about the statistical significance in the next slide. And regarding the secondary outcomes, that is the complications during the first 7 days and even 3 days, they were almost similar among both the groups. So this is the Kaplan-Meier curve, which is showing the survival rate of both the groups, liberal and the restrictive group. So in the start, the survival is around 1 for both the groups. And as you can see at the end, the liberal strategy has less survival compared to the restrictive strategy. But the p-value is just 0.903, and hence there is no statistically significant non-inferiority of the restrictive group. So this is the forest plot, which is showing the results. And as we all know, the line in the vertical line in the middle is the line of no effect. So that is usually, in superiority trials, usually the confidence limit has to be just to the side of, just either side of to favor the restrictive strategy. For example, here it has to be to the right side of the midline. So for non-inferiority trials, we have another vertical line, the dotted vertical line called the non-inferiority margin, which we were discussing earlier. And in this non-inferiority trial, the confidence limit has to be on one side of either the non-inferiority margin, not the line of no effect. And hence, in this study, since it is a non-inferiority study, the line of confidence limit is, since it is crossing the non-inferiority margin, there is no statistically significant non-inferiority of the restrictive strategy over the liberal strategy. So the final results of the study were the 28-day survival rates were 92% and 91% among the restrictive and liberal groups respectively, and there was no statistically significant non-inferiority observed. The transfusion volumes, hemoglobin levels were lower in the restrictive group than in the liberal strategy group. And there was no between group differences noted in the complication rates or even 3 days in the among the groups. Thank you.
Thank you, Dr. Kirti. Dr. Kirti, what do you think about the study? Can you just summarize and give us your view? How good is the study, and what's the internal validity of the study?
Okay, ma'am. So as we discussed already, it is a multi-center trial done in Japan, which compared the restrictive RBC transfusion strategy with the liberal RBC transfusion in trauma patients. So the research question was relevant, which we have discussed already, and the objective of the study is also very clear. And as I told already, since cluster randomization is used, the selection, there is a possibility of selection bias, and since it is non-blinded, which can also increase the risk of performance or detection bias, and regarding the sample size, they have mentioned that there is a error in the sample size calculation, and sorry. So there was an error in the sample size calculation, and since they couldn't note it in the start, it was conducted found only in the end, and since due to and otherwise the groups were similar, and the other than the intervention, the treatment given to both the groups were also similar, and the intention to treat analysis was used. That is also very good, and the outcome measures were clearly defined, and the primary and secondary outcomes were clearly explained and defined.
Okay, thank you.
So I'll just Justin here. I just be a spoiled sport. Obviously, it is called a critical analysis of a journal. So can I request Kirti to just put a slide about the hemoglobin concentration level? That slide on that bit, yeah. Yeah. So obviously, when we look at the title itself, it says bleeding. So we are looking at the bleeding patients. And so when we look at the bleeding patients, so as a critique, I'm trying to look for as many holes as possible in the study so that it does not change my practice. And that's my duty. So I'm looking to see when a patient is bleeding, they are bleeding full volume. I think Ajit is, we remember discussing when they don't lose hemoglobin, they lose blood volume as it is. And so as the graph suggests, the divergence in the hemoglobin concentration only happens after, probably the proper divergence only happens after 24 to 48 hours. Really the both arrows missing. So that actually is what the bleeding is all about. I think so. No patient who has had a bleeding is only hypovolemic. They generally develop surge response within 3 to 6 hours of any bleeding that requires transfusion, and as an added component to hypovolemia. So, which obviously causes shift in your fluid volume other than exogenous fluid that we are giving some fluids and other things. So, which makes the numbers look divergent at that time, which is 24 to 36 hours is the time when they diverge. And as a critique, I don't think that these both groups had any significant bleeding to say. By looking at it, they look like as if they are in the same group. And that is just that you gave a hemoglobin a little bit more than one to the other. Otherwise, they both would have been the same group. Yeah, so that's good. So essentially, first 6-12 hours, which is the major time for resuscitation, is no different to them, irrespective which choose, because hemoglobin loss or change is not dependent on surge response. And whatever your change in strategy for hemoglobin is probably not for the bleeding, but for the surge or other extragenous features, for which we have enough literature to say that we don't have to give transfusions for SARS or sepsis. In a way, if you want extra. So as a critique, I'm saying this to you. The second main problem for me with this trial is that it says as trial design is pragmatic, a real world. In a real world, you never have two groups matching each other so precisely. I'm always worried when it is too good to be true. I wonder why it is. Number three, there are always what is called as confounders, allocation, concealment, and biases, which are very important for us whenever we see these kind of articles. Concealment is not possible in terms of intervention because your urine is getting. So for this reason, there is randomization. And in this group of patients, the cluster randomization is not a traditional cluster. What they said is that, okay, fine, Pushpaberi is one of the recruiting units. And for 3 months, you're going to do restrictive first. And then you have 1 month washout period. And then you do the liberal. So Pushpaberi does 3 months of 8 to 10 or 7 to 9. And then 1 week washout. But the behavior doesn't go away, isn't it? The behavior of the ER physician or ICU physician does not go away easily within one month. They've realized that it is okay because everything is about restrictive in life now in ICU. So tomorrow, when the other month comes, you are always aiming for 10, not 12. So you fall sometime below, isn't it? So that's the reason why the divergence is not high between 6 hours to 24 hours or 36 hours. And that tells me that the practice physicians, actually it is a pragmatic study, but some of the values are too good to be true. But I guess when you look into the study, it's the behavior of the clinician that is highlighted here. And the study isn't all about the hypovolemic shock, but probably management of hemoglobin change after the initial 6 hours with whatever may be the reason. It could be hypovolemia still. There may be some patients who are still bleeding. Okay. When I'm looking at these things, when these patients are being analyzed, I want to see how sick these patients are. Like, when I have Apache 10, Apache 2 of 10 or 12, I don't think they're too sick. On a day, I don't predict them to die. You come Apache of 25, 35, I know that they are likely to die. Isn't it? Similarly, injury severity score of 25 is equal to around 8 to 12% of mortality, and they have 10% mortality. So a 10% mortality in an ICU patient is something that you do not consider them as sick patient in general. When you don't have a sick patient, you cannot show mortality difference anywhere, no matter what intervention you give. So it's going to be a really moot point in that sense. So these are some of the comments that I come up with as a way to create doubt in an assessor. How should I use this trial? And what sort of holes that I should put into this trial? And what it means to me in terms of my own practice, whatever you're doing now, whether it's liberal or restrictive. And I would request Pradeep and Ajit, Matthew and Manju to probably make some more comments or contradictory comments to mine so that we can take this discussion a bit better. Thank you.
Thank you. Thank you, Justin. I think, Justin, you made very valuable comments. So in fact, I was surprised that this journal was picked up by Anirban because very coincidentally, we had discussed this journal, which was presented in my department as well by my trainee. And I was overtly critical about this whole article because the first question that I would ask is, was there a need to do this study? So Kirti, if I can put that question back to you and ask you, was this study really needed? The answer lied within that manuscript. So can you reflect on what were your thoughts as to why authors felt this study was needed? Because as Justin said, we had reasonably good body of evidence that in ICU, we have a transfusion thresholds of 7 restrictive in nature, by the way. And we have even accepted that as a quality indicator in ICU. So given that standpoint, why do you think these authors embarked on doing such a big trial involving 22 ICUs in Japan? There was so much of resource put in. So do you have any thoughts on that, Kirti?
Yes, sir. As you mentioned, there are enough studies to support the restrictive strategy. Like there is a trick trial, which is done in patients admitted to ICU, and it showed there is a restrictive strategy superior to liberal strategy. And in TRUST trial, which was done in patients with septic shock, it has shown similar results. And in trick 3, which is done in cardiac surgery patients, restrictive was non-inferior. So all these studies and another one was done in oncological patients, which is the one which favored the liberal, and a reality study which is which was done in myocardial infarction patients, and it showed the restrictive was non-inferior. And another study which was done in acute upper GA bleeding, it showed a restrictive strategy significantly improved outcomes. But I think the difference is here is it is an acutely bleeding patient, so the clinical setting is little different.
Yeah.
So all
So
these
I
are
think,
patients.
yeah, so that's right. I think you've gone through the whole body of literature. So there are good number of good studies from which we have gained insights that we don't need to unnecessarily restrict. So the authors say that the only reason they had to do this was because acute bleeding was excluded in the previous studies, and randomization in all those previous studies was done within ICU. So this was more like a ER based study. And if you look at the authors, possibly they are from emergency department. They said randomization happened in emergency. These are the only two reasons that the authors cite. And as Justin has very critically pointed out, that when they say they have included active bleeding, and which he has rightly reflected upon from that graph, that possibly these patients were not actively bleeding to a point that they needed. Because ethics, I was asking my trainer as to how would this get an ethical clearance when you have an actively bleeding patient, your whole emphasis would be on to prevent the lethal triad. And if you restrict, they would have this coagulopathy setting in, or hypothermia and acidemia. So which is something as an ethical committee, I wouldn't give a clearance to a study in an actively bleeding that you allow coagulopathy to set in by restricting, isn't it, in an acute case? So these are some of the criticisms that would automatically come out when you are doing this, and possibly they should have reflected a little more on the type of cohort of patients. Were they all, whether they had a significant cardiac history? So I don't know. I couldn't find it. I don't know if you could find as to whether they had cardiac comorbid conditions and whether there was some biases put in there with regards to stratifying these patients, because there are patient-specific sort of an approaches that we have in certain groups in being overtly restrictive versus liberal, isn't it? Even liberal would be dangerous for a heart failure. So on and so forth. So there are a lot of lacunae, and even the first thing which you really pointed out well is the sample size calculation was atrociously gone wrong. And despite that, the authors go on to say that this was a reasonably good sort of a study to indicate it is non-inferior. And the 3% calculation, what they did as a intention to treat non-inferior margin, was it for the previous sample size or was it for the present sample size that they finally deduced to? I'm not sure. So I don't think authors make clarifications on that. So there are extreme degrees of loopholes, lacunae, and imperfections in these trials. And I don't think this has added anything to our current day practice in any way, or my interim thoughts. So they've done it, they've embarked on doing something, so they just have come out with some publication. So it wouldn't change our practice in any way. Even if you had said non-inferior, so what does that mean? So would you restrict your trauma or would you be liberal with trauma? So it leaves with a lot of open-ended questions. So that would be my comments. So thanks very much, Kirti. Very well presented. And Ajit and Matthew, you can also give your comments, and we can take any questions from audience. I don't see any questions in the chats, so which is surprising to me. Ajit and Matthew. Yeah.
Dr. Ajit and Dr. Matthew, the figure 4, if you see the matching of the RBCs between the two groups and the FFP, the first 6 hours, the RBC transfusions are the same in both the groups. I think, and then the first 6 hours, FFP transfusion is also the same. And if you look at the number of units, there are more than 5 units of FFP and less than somewhere near to 5 or less than 5 units of RBC transfused. So they also mentioned that the liberal strategy was equivalent to the massive transfusion protocol, something like that. They considered massive transfusion as the liberal strategy. So what do you think about these things? Like, the 6 hours, both are getting equal.
I have a feeling, as Dr. Pradeep has said, that the first 6 hours, both the arms were somewhat similar, treated somewhat similar. actual changes happened probably only after the initial resuscitation. That's what I think from the graph of the study. The first 6 hours, both the groups received around equal blood. It does differ after that. Probably that is after the initial resuscitation was over. So one of the main claims made by the authors that the strength of the study is that there was a there was a difference in the emergency itself. It's not there in the graph that we can see. So again, one of the problems. One of the reasons why we put up this study is just to highlight how problematic, a study in which even the sample size calculation is not adequate or totally inadequate has come in a reasonably major publication. And, unless we do a proper journal review, please do not take journal in face value or the results in face value. I think that is something that has to be clearly shown to all the students that read journals. So please please look at this as one of those things where, absolutely atrocious, as you said, the sample size calculation, and still published. So, well, something that we'll have to look into.
So I think from a sample size point of view, probably I can make a comment. Probably this is more like a pilot study that they would have done for a 4,000. Let's, for example, read this trial as a pilot project for another trial, which is probably actually adequately powered for like 4,000, 5,000 patients. So in that sense, a pilot study says that feasibility or not. Probably I would find that it is non-feasible unless it is a multi-country study. So maybe tomorrow they may be able to entertain Europe or US to join with one of these studies to come up with 4,000 patients. So that's probably realistic for tomorrow. So in that sense, it may persuade, the publication of this article may persuade others to come together to join for 4,000 patients, because it has shown at least imperatively that it is non-inferior, at least, at least adverse events were not, like it is deemed as a safe, like how you would call a phase 2 trial. That essentially that's what it has done. So in that sense, it may be still informative to do a proper stage 3 trial. So that's probably what, as critical as I am, I probably would cut that slack for them. So that's
yeah. So that's the thing. The sample size, it is very shocking to see that, because multiple, as acknowledged by the authors, multiple statisticians were involved, before the trial. So based on that, the calculation was 400 for this, this margin of around non-inferiority to have a margin of around 3%. But at the end of the trial, they could not notice that. After the trial is over, they came to know that there is a gross error. It is 6,000. The expected thing for the previous one is 6,000, and here it's only 400. So there is a very huge, unbelievable error has happened. It is 6,000 is after the end of the, during the trial nobody was aware. After the trial is over, is detected that there is a gross error is happening in spite of multiple statisticians involved. So basically, to me, this trial has it has failed to prove anything. Nothing. It doesn't show anything.
And in fact, the conclusions they make is it is non-inferior, but even authors mention, although this study could not statistically confirm the non-inferiority, which means they are only being contrary into expressing the the fallacies in this study. So they have acknowledged it. They have only written that we cannot mention it.
So
I have a doubt in this. I have one doubt is that when the patient is actively bleeding, so you won't be looking at hemoglobin, isn't it? Because I think that there also, so you'll be just giving blood, isn't it? Then how will you decide whether it will go to liver or the restrictive strategy?
Sir, I think that's exactly the point. Although they have added the patients from ED onwards, they have randomized ED onwards.
Yeah.
The actual difference has started only after being in the ICU. Once the hemoglobin started probably, showing different results. See, in the ED, they have 2-3 options of giving anyone whom they suspected to have active bleeding, anyone who had a hemorrhagic shock. Even if the hemoglobin is normal, you will still give blood, isn't it? So
No, when the patient is actively bleeding, you give blood, isn't it? Then only you'll check the hemoglobin, isn't it?
Yes,
So
yes.
sometimes you can overshoot, no? This, whatever you give, then how they do the,
Yes.
that.
If you see the first couple of hours, maybe the first 3 hours, the hemoglobin is just the same, but they have given blood in the first 6 hours.
Yeah.
They have given blood. The hemoglobin is the same. So I'm just probably like those patients were bleeding or they were expecting the patients to bleed. So they have given blood there.
So this is one of the differences between how we cannot extrapolate to us is because in overseas, or particularly in this case, trauma, when the patient gets retrieved to a hospital, the ambulance services, from the time they pick up, they call the hospital, let them know the vitals, what's the gravity of the situation, and ongoing process, whatever they are doing. So by the time patient arrives in emergency, which may be 6 minutes to 60 minutes, whatever the retrieval time, so there are resources set up, including a level 1 transfuser setup with the bags of blood. If the active bleeding is there, they will set up a bleeder. So you already primed to give at least 1 or 2 bags of blood. Like in level 1 center, you have 2 bags. They will set up warmer and connection. So majority of the patients would actually get transfused, even though they may not necessarily have severe bleeding, just because there is an external bleeding and the severity of the injury was deemed severe. It may not actually be the case. So this is what we see. Sorry.
The transfusion protocol would have been already activated. So they just, and the blood is already there, blood and the plasma, and then just give it off.
The triggers for massive transfusion and transfusions are little bit probably on the lower side in an emergency, but first 3 hours particularly, or first hour, let's say, compared to other. So that way, the minute they see a blood, whether you are in restrictive or otherwise, you get the same blood. Yeah. So which is a little bit different from India, where you start work after they come into ICU or ER.
Yes.
And work doesn't start. So you start then and then do this. So we have a lot more restrictive strategy.
Yes.
Yeah, we have a restrictive strategy.
Yeah. So I think Dr. Manju, we can close this. I think we have already exceeded our time. So it's close to 8 o'clock now, 7:50. So any quick closing comments from each one of you, and we could possibly close this, isn't it, Manju?
Yeah. So what's the final take? Final take is this is not properly done study. Internal validity is not great. And for the same reason, external validity is not great. And then the system is completely different in the 2 countries. So again, that also says that we cannot take it at the face value of the study. I thank everyone. Thank you for the opportunity. And I think we can wind up now.
Thank you. Thank you all.
Thank you. Thanks.
Thanks, Dr. Kirti.
Thank
and
you.
All the best.
Thank you. Thanks.
Thank you, Vinay.
Thank you.
Thanks.
Thank you, Matthew. Thank you. Take care.
Thank you.
Thanks.
Thank you. Thank you.
Thank you, Matthew.
Justin.
Thanks.
Bye, Justin. Yeah.
Bye-bye. Bye-bye.
Bye.